Okay, so we are going to delve into normal skin histology for this part of the lecture. So this is actually just a picture of normal skin. And so you can see the three major layers of skin. You have the epidermis, which can range from a fraction of a millimeter thick, like on the eyelid. It can be as small as thick as 0.1 millimeters on the eyelid, and going all the way up to 1 millimeter thick on acral skin, such as the palms and soles, palms of the hands, soles of the feet. It can be actually 1 millimeter thick just for the epidermis alone, including the stratum corneum. So we'll look at some examples of that. But this is probably on just some proximal extremities or trunk. This is your typical skin histology, where you have your epidermis and your dermis as the middle layer. So you see the dermis can be 1 millimeter thick to 4 millimeters thick, depending on where you're at. So on the face, you could be at 1 millimeter thick. On the back, you could be up to 4 millimeters. So it's almost a half a centimeter thick. Think about the width of a punch biopsy tool. So the dermis can actually be that thick on the back. And then subcutaneous adipose tissue. That's where you have most of your adipocytes, as well as the base of anagen hair follicles. You have larger vessels there. You've got some areas of the apocrine glands seated in the subcutaneous tissue as well. Now, when you have a spongiotic dermatitis, you're going to have most of the pathology up here in the epidermis. And typically, I like to think that epidermal pathology trumps any other type of pathology when we're classifying what's going on. So if you see a significant epidermal pathology, you definitely, that can direct you to your differential diagnosis. You can have spongiosis within the epidermis, swelling in between the keratinocytes. You can have psoriasiform hyperplasia, where you're getting a lot of just bulbous, regular hyperplasia with extension of the reedy ridges going all the way down. And you'll see examples of that in other lectures. You can have an interface dermatitis, which could consist of dense lichenoid inflammation, where you have a dense band of inflammation running up here in the parallel fashion in the superficial dermis. You can have a little bit of vacuolar change is another part of interface dermatitis, where you have these vacuoles forming at the basal layer of the epidermis. So those are kind of the major epidermal inflammatory processes that can happen. In the dermis, you can have deposition of numerous types of inflammation. You can have cutaneous lymphomas developing here. You can have histiocytic processes such as granulomatous inflammation, granuloma annulare, for example. You can have deposition of materials such as mucin and mucinosis, or amyloid and amyloidosis. So the dermis is a source of a lot of derm path as well. And many epidermal neoplasms can extend down into the dermis and even reach to the subcute. Subcutaneous tissue, lipomas can arise from the well-differentiated adipocytes here. You can also have atypical lipomas tumors, or even liposarcomas arising from the subcu. In terms of inflammatory, you can have many different types of paniculitis, where you have either septal paniculitis, which is widening of the septum in between these lobules of fat, or you can have more lobular paniculitis, where it's spread out throughout the adipocytes. And we'll get into those different categories in a different lecture as well. So you need to understand the normal skin histology, and so that way you can identify what's abnormal. And that's the first basic step of understanding dermatopathology. So let's take a closer look at the epidermis here. The top layer is the stratum corneum. It's composed of essentially anucleate or dead keratinocytes. It forms that first external barrier and prevents a lot of external substances from crossing into the epidermis or the dermis. So this is your stratum corneum. This is where you'll either get hyperorthokeratosis, where you've got a lot of just this anucleate stratum corneum. It can be compact, or it could just be basket weave like this. This is orthokeratosis. And then you can also have perikeratosis. And perikeratosis is where you have retention of the keratinocyte nuclei, and that usually suggests some type of faster cell division is happening. Oftentimes when you have parakeratosis, which you do not see here, you'll have an underlying hypogranulosis underneath that. And that'll become important in a lot of different entities that we will discuss. Next layer is the stratum granulosum, or the granular layer. You can see these kind of more purple keratohyalin granules. And keratohyalin granules refer to a more basophilic component of the epidermis that has a lot more of a protein called filaggrin in them. So this is an area that normal skin should have some type of granular layer preserved. There are some exceptions in different areas of the body, which we'll talk about, that lacks granular layer, but more often than not, any normal skin site should have some preserved granular layer. Now, you might get hypergranulosis, which could indicate things are happening, like lichen simplex chronicus. You can see hypergranulosis, for example. And you may have hypogranulosis, where you can barely see a granular layer or it's completely gone. And that often happens in psoriasis. Just to throw those terms out there for introductory. Stratum spinosum is making up the bulk of your epidermis. That's where you'll often see, when you have spongiosis or swelling in between the keratinocytes, you'll see the actual connections between the keratinocytes. And it's a little bit hard to see on this image, but in real life under the microscope, I'll take you to high power and you can really appreciate the desmosomes in spongiotic dermatitis. That's where you have your desmoglians and proteins that are connecting your E-cadherins, your desmoglian proteins that are connecting the keratinocytes together. And it's quite fascinating to see the little lines, spiny processes between the keratinocytes during spongiosis. It's one of the fascinating parts of cell biology to think that all these keratinocytes are really networked together through these intercellular proteins that are really pronounced during spongiosis. So that's the stratum spinosum layer. You also have the stratum basalis layer. And so this is where your basal keratinocytes, your stem cell keratinocytes, the ones that are creating all of the upper level stratum spinosum cells, the granular layer and the stratum corneum. It all arises from this stratum basalis, or basal layer. So if you were to do a Ki-67 stain to highlight proliferating cells in the epidermis, you're going to find that a lot of that Ki-67 highlights along the basal layer, where the cells are actively proliferating and creating these new epidermal cells above it. Now, the turnover for to go from the basal layer all the way up here could be up to 2 weeks or 14 days, and going from the stratum granulosum to the stratum corneum can be another 2 weeks. So, but every month, essentially, your epidermis renews. So why do you keep the moles that you have? Why do you keep? Because the melanocytes are not dividing that fast, and the melanocytes are the ones that are producing the pigment. They're the ones that are sticking around. They're not renewing nearly as frequently as your keratinocytes. And so, how do you know what a melanocyte is? Here you see this kind of paler cell with a little bit of a grayish nuclei. It's going to be your melanocyte. It marks with melana for a cytoplasmic stain and SOX10 for a nuclear stain. It lacks desmosomes as well. And one melanocyte is occurring as you go along the basement membrane for approximately every 10 keratinocytes. So here's another, for example, here's another. And each melanocyte actually has dendrites that touches and delivers melanin pigment to 36 keratinocytes. So it's pretty networked here. The epidermis is very complex, and it's got a lot of intercellular communication and networking happening. Now, of course, if you think that I'm going into a lot of detail, that's because I'm a cell biologist. So I really love the cellular aspects of dermatopathology. That's how you make sense of what you're seeing. So getting on into the epidermis, we'll start out at the stratum basalis, or the basal cell layer. Here we mark it in a green box, and you can see the basal keratinocytes They are essentially stem cells, and the morphology of these cells are that they're cuboidal or columnar in nature. They have prominent nucleoli, which is where a lot of the RNA is made in the cell nucleus. It's okay to have some occasional mitotic figures because think about it, the epidermis is dividing. So at any given point, when you take your biopsy and you fix that specimen, and by the time you get sections made of that specimen, you're going to see mitotic figures in the epidermis. That doesn't mean that you have some type of malignancy. It just means that normal cellular mitosis is happening. Now, you'll get a sense for how many mitotic figures you'll see in normal skin. And when you look at Bowen's disease or squamous cell carcinoma in situ, you will see many mitotic figures. And so that'll give you a sense that there's actually a malignancy happening in the epidermis. But seeing one mitotic figure does not mean that you're dealing with malignancy, okay? And these cells mark with CK5-6, which are intermediate molecular weight keratins. They can be, some consider high molecular weight keratin. The basal cellular layer is often marked by keratins 5 and 14 as well. That's a basic science tidbit that you'll need to remember for your exam. As you go up into the stratum spinosum, you'll transition to keratins 1 and 10. Melanocytes, as we mentioned, they're the cells that make melanin pigment. As I'm sure you know, they have more of a clear cytoplasm to a gray cytoplasm. They can have the brown pigment granules, but keep in mind that the cell that's most commonly going to have the pigment granules are the keratinocytes, because the melanocytes actually deliver the pigment to the keratinocytes. As I said, 1 out of every 10 cells in the basal layer are melanocytes. So there's 1 per every 10 basal keratinocytes. And each services or delivers melanin to about 36 keratinocytes on average, depending on the thickness of the skin, et cetera. If you were to stain a melanocyte for melanate, you could see dendritic processes, extension of the cytoplasm in between the epidermal keratinocytes, which is quite fascinating. And we'll get to examples of that later on in the lecture series. For junctional proteins, you've got desmosomes, which hook up the cell-to-cell connections, and you have hemidesmosomes, which hook up the cell to the basement membrane. And there will be some basic science lectures in which we go into this even deeper in terms of the names of the proteins and how they're all interconnected. As I mentioned, the spinum or the stratum spinosum, or the Purkinje cell layer is commonly referred to. These contain the maturing keratinocytes. From the basal to the stratum corneum takes about 14 days to travel that distance. And the morphology of these cells are relatively polygonal. So understanding that most benign proliferation of the epidermis or acanthosis, you'll have these kind of equidistant spaces where each cell has its own approximate area that's about the same. And that'll give you a sense of normal acanthosis. You don't want to hallucinate nuclear pleomorphism. You don't want to hallucinate cellular atypia when it's not there. And so understanding that there's a little bit of variation in nuclear size, because you're cutting through a plane of section, you may not get through the middle of every nucleus, you may be catching the edge of some nuclei, but getting a sense of just the normal distribution of the keratinocytes and seeing this normal white delineation between cells with the connections of the desmosomes in between, you have to look at a lot of epidermis before you really get a good sense of this. And it can be a little tricky, but just start to gain an appreciation for that. And that's a part of the optical mileage that I mentioned in the last lecture, that you have to look at a lot of epidermis to really get a good sense of it. Langerhans cells are the sentinel immune cells of the system. The markers for Langerhans cells include S100 as well as CD1A. And they often will have clear cytoplasm, but they're hard to really appreciate on just H&E staining alone. So if you really want to visualize the Langerhans cells, you're going to have to do markers on immunohistochemistry, and those consist of CD1A and S100. that becomes important when we study concepts such as Langerhans cell histiocytosis. Moving on to the stratum granulosum, or the granular layer. These are keratinocytes with dense purple punctate keratohyalin granules. They help keratin formation. They help seal the barrier with keratohyalin materials, including filaggrin protein. And that filaggrin protein is defective in atopic dermatitis oftentimes. So the skin barrier is actually disrupted quite a bit in atopic dermatitis. And that granular layer can be hypergranulosis or hypergranulotic in diseases such as lichen simplex chronicus, where the patient's scratching so much that there's a huge proliferation of the cells even in the granular layer. You can have a wedge-shaped hypergranulosis in lichen planus. And the key hypogranulosis disease is going to be psoriasis. So there's so much quick cell division that the cells just kind of skip over that granular layer process and go straight up into the stratum corneum, where they retain their nuclei, and you get confluent hyperparakeratosis, which we will show some examples in later lectures. The stratum corneum is that very top dead layer of skin. It's normally anucleate. So if you see retained nuclei there, then you are dealing with parakeratosis, not basket weave orthokeratosis, which is what you usually see there, okay? So normal pattern is the basket weave orthokeratosis. The function of the stratum corneum is it's going to restrict water loss, and it contains endogenous antibiotic molecules. So things, there are certain types of antimicrobial peptides that are produced, and we will actually get into some of the specifics of that in later basic science lectures. Cathelicidins would probably be the most recognized protein in that category. Now for the dermis actually has different compartments. So the very top layer of the dermis is known as the superficial or papillary dermis, where you have thinner, looser collagen fibers. You have the superficial vascular plexus, where you're going to find a lot of vessels there. And I'm circling a lumen of one of the vessels here. So if you've got dilated or ectatic vessels, you'll see them here. If you've got leukocytoclastic vasculitis, you may see actual neutrophils and fibrinoid necrosis around the vessel and extravasated red blood cells around that. And we'll get into vasculitis. That's a fascinating topic in dermatopathology. And then the deeper part of the dermis is called the reticular dermis. That makes up the majority of the dermis. You have thicker, irregular collagen fibers and elastic fibers. Subcutaneous adipose tissue is where you get a lot of the cushion of the skin, actually. So if someone's pressing on the skin, that kind of give and take, that bounce back, a lot of that absorption is actually in the subcu. So this is where subcutaneous adipose tissue deposits during weight gain, or during the development of lipomas, during the development of liposarcomas. It all arises essentially from this subcutaneous adipose tissue. Now, if you feel clinically that somebody's skin has got this indurated plaque where you're pressing on it, it loses that give, that push, but it doesn't have a lot of epidermal surface change, then you clinically suspect that something's happening deeper, such as a paniculitis. And so we've had many cases where you'll feel the patient's skin and you'll feel it's lost that squishiness, that give and take. And in that case, if you do a biopsy, you're going to want to do a biopsy to remove the top layer of skin. And then you're going to want to do a punch biopsy within that punch biopsy to get more of that fat. Because really you want to make sure you're getting enough fat to diagnose a paniculitis if you have it. So if you go in higher power, you'll notice that the lipid droplet actually takes up most of the cell for an adipocyte. The nucleus is located eccentrically, and the cytoplasm is very eccentric as well. So most of the lipid is actually washed out during processing of the slide. And so you're left with this empty white space, and that represents the adipocyte. The subcutaneous tissue has septae and lobules. So septae are the thicker collagen divisions between these lobules, which are made up of mostly adipocytes. So depending on where that inflammation is in a paniculitis, you're going to be able to call it septal or lobular. Septal, the most classic example is your erythema nodosum, which develop as kind of these deeper seated nodules on the legs most frequently, sometimes after infection. It could be associated with other systemic diseases. And lobular paniculitis, the list is too long to mention for this lecture, but just understand that there's a whole host of entities that can lead to lobular paniculitis. Also remember that nerves and muscular arteries are within the septae of the adipocytes. So oftentimes if you've got a large vessel vasculitis, you need to get down into the subcu to be able to sample these larger vessels. Adnexal structures are very, very important to understand the normal histology of, because you get, with every one of these normal adnexal structures, you could have a whole host of different types of adnexal neoplasms that can arise from them. So in terms of hair follicles, there are different stages of the hair follicle cycle, and we will briefly mention that, but this is kind of a representative follicle here in this cartoon. You've got the dermal papilla that's located right underneath where the dermis kind of comes up underneath the hair follicle. Around that, you've got matrix cells. And then you have the papilla of the hair, which is made up of a cortex and a medulla. And the medulla is in the center, the cortex is to the edges. And this is essentially specialized keratin that extends all the way out into the outer surface, and that's what gives you the hair shaft. The pigment that that gives your hair some color, that is made by the melanocytes, which actually sit at the base of the bulb of the hair. They're kind of near the matrix cells, and we'll look at the histology of that. Now, you can have adnexal tumors that arise from different levels of the hair follicle. So you can have cells that arise more from the matrix cells or the cells from the outer root sheath. You can have neoplasms that are arising more from the infundibulum or the isthmus. You can have cysts that develop from the occlusion of the follicular ostia and cause different types of cysts. So hair follicles, including basal cell carcinomas, are intimately tied to hair follicle dysfunction or development dysfunction. So understanding normal hair follicles is going to be critical for understanding neoplasms, but not only just neoplasms, but alopecias as well. So we're not going to be able to get into it, but for this lecture, but there's a whole host of different types of alopecias, and understanding the normal hair follicle structure and understanding the normal hair follicle cycle will get you one step closer to understanding alopecias, which are essentially hair loss due to various types of pathologies. Sebaceous glands are one of my favorites in the skin. So it's responsible for producing oil, so it keeps our skin protected and hydrated. But it can also, when overproduced, cause to follicular plugging and development of lesions such as acne and oily skin. It can be the source of cosmetic concern as well, as patients don't necessarily like to have oily skin. However, do keep in mind that sebaceous glands do serve a purpose of keeping the skin hydrated and protected from the environment. So it's been thought that patients with oily skin often retain more youthful features because their skin's so hydrated. That being said, it's a very difficult balance. And so over oily skin or production of oily skin that's mixing with dead keratinocytes leading to acne can be a problem. But the sebaceous glands themselves can actually lead to a whole host of neoplasms. So you could have sebaceous carcinoma, which is the worst, but the most benign would be sebaceous hyperplasia. And those often show up as very kind of yellow small papules with enhanced sebaceous glands with a central bell in the center. And so You can have sebaceous adenomas and sebaciomas develop from that. And we'll go over the details of that at another time. But just understand sebaceous glands are a huge cause of sebaceous neoplasms. And you can have a lot of them even on the face. And so if you have a lot of sebaceous glands on the biopsy, you can predict you're probably on the face. Now together, the hair follicle and the sebaceous gland, they make up something called the pilosebaceous unit. So there are areas of the body where you do not have pilosebaceous units, such as the palms and the soles. So you don't have sebaceous glands and you don't have hair on your palms and soles. What you do have a lot of though in the palms and soles is going to be your eccrine glands. So the eccrine glands are another derivation of pathology. So normally this produces sweat for us. So the eccrine gland is also known as the sweat gland. And you can see this coil here that's located deep down and near the dermal subcute junction. And the sweat gland has coils down here. That's where the glands are that produce the sweat material. Then you've got the duct coming all the way up to the outer surface, to the acrosyringium, as it's called. And that's where the sweat actually comes out onto the skin. So the palms and soles are, and obviously the scalp as well. Just think about where you normally sweat. That is where you have a lot of eccrine glands. Now, there are certain parts of the body that do not have eccrine glands. So just think, where do you not sweat, right? That's going to be the areas that you do not have sweat glands. So examples would be genital skin does not have sweat glands. Obviously the oral mucosa, things of that nature, the eyelids, all of that. But in those areas that we just discussed where you don't have eccrine sweat glands, you might have something called apocrine sweat glands. So things like areas of the axilla where you're producing these specialized secretions. You could have apocrine glands in the axilla as well as in the genital area. You can have ectopic apocrine glands even in conditions such as nevus sebaceous. You've got a lot of apocrine glands there. Apocrine glands can be highly present in around the nipple area as well and are associated with breast tissue. So apocrine glands have a specific histology that we will show examples of later in this lecture. Vessels are located all throughout the skin. You've got really small vessels in the superficial dermis. And as you go into the subcu, they usually get much larger. You can have arteries and veins deeper down that transition into arterioles and venules. And you, of course, have capillaries as well. And think about vascular proliferations. So you might have hemangiomas that are mostly arteriole based. You might have some that are mostly capillary based. You might have some that are mostly venule or venous based, and you may have some that are lymphatic based. So all normal components of the skin can lead to dermatopathology. And that's why you really have to understand the normal structures. One thing I failed to mention is the erector pili muscle. So you can have something called a piloleiomyoma, which arises from the erecti pili muscle. You can also have an angioleiomyoma, which arises from the smooth muscle of vascular structures. So every single part of the skin that you see, including the nerves, so you can have neoplasms that are derived from the nerves, such as neurofibromas. You can have schwannomas developing, plexiform neurofibromas can develop in diseases such as neurofibromatosis. You can have a whole host of neural neoplasms that can develop in the skin. And so just understanding that every normal component of the skin can develop into a dermatopathology. And this does not even talk about the inflammatory component, which includes different cell types. And so as you can imagine, DermPath has a lot of representations of normal derivation turning into abnormal, and you have to know the normal first before you can understand the abnormal. All right, so here's an example of a pilosebaceous unit. You can see very nicely the adipocytes extending off. Sorry, not the adipocytes. The adipocytes are here. The sebocytes extending off into the sebaceous lobule. And they produce oil, which goes into the follicular ostia and out to the outside surface of the skin, producing that oil to the skin. Immunohistochemistry wise, sebocytes are marked by adipofillin, and there's a new kid on the block called PRAME, which is a protein that's been found to be highly expressed in malignant melanocytes, but not abnormal, and not normal melanocytes. But interestingly, PRAME stains nothing normally in the skin except for sebocytes. And so the sebaceous glands highlight beautifully with the stained PRAME. That's been a fascinating observation that we've made as we learn more about proteins that are expressed in the skin under normal conditions as well. So PRAME has been proposed as a good marker for sebaceous carcinoma as well as melanoma. Adipofillin is your key marker for sebocytes. And here, you kind of can't tell where the base of the follicle is going, but this could be a telogen or a catagen follicle because it doesn't have a bulb that seems to be that deep into the subcutaneous tissue. If you've got a really thick hair follicle that's got a lot of clear cells, and this has like a little bit of clear cells, so maybe it's actually involuting from an anagen to a telogen, an anagen to a telogen phase through the process of catagen, and you'll have apoptosis of these cells here, which give this kind of nice pink, hot pink transition at the base of the follicle, at the base of the hair shaft there. So that can be a hint. Here's your nice pili erector, erector pili muscle that is responsible for goosebumps. So the reason that the skin stands up is when these things contract, it straightens up that hair follicle and causes what the common term is goosebumps. Of course, this pilar erecti muscle or erector pili muscle is a source of piloleiomyomas when they develop in the skin, or smooth muscle tumors. Hair can be either terminal or vellus. So when we talk about a terminal hair follicle, we're mentioning an anagen hair follicle where you've got the base really deep seated into the deep part of the subcutaneous tissue. Most of the follicles are in anagen, and we'll go into the breakdown here on one of the next slides. You can have telogen hair follicles, which are seated up higher. And the transition from anagen to telogen is known as catagen. That's usually only a process of 3 weeks or so for the anagen hair follicle to transition to a telogen hair follicle. The telogen, while the anagen hair follicles can be present for 2 to 6 years, the telogen hair follicle can be present for about 3 months, and then it often will release the hair shaft and enter back into the anagen hair follicle stage. That's the normal hair cycle. Catagen only lasts about 3 weeks, and that's the intermediate stage. Many diseases result in what we call an anagen to telogen shift. So the ratio of anagen hair follicles, it goes more from anagen hair follicles to telogen and catagen. So that shift is important to recognize. In a normal 4 millimeter punch biopsy, you'll have up to 10 hair follicles being counted. And that can be normal. You can have above 20, even up to 30 hair follicles on cross section. And if you were to section this horizontally instead of vertically, you could actually get a cross section bird's eye view and be able to see even up to 25, 30 hair follicles in a single 4 millimeter punch. That goes a little bit beyond the scope of this lecture because we will talk about alopecias in a different lecture, but I want you to understand the basics of hair follicle structure here. Also important is to understand vellus hair follicles. So vellus hair follicles are really those miniaturized follicles. So in androgenetic alopecia, you have miniaturization of follicles, a lot more vellus hairs than terminal hairs. So someone's got a really thick beard on their face. They've got a lot of terminal hair follicles on their face, but their hair is thinning on the top, and they're what you would call bald on the top, but they actually have small little miniaturized or vellus hair follicles, which sit at the very top layer of the dermis. So they still have the hair. It's just, it's transformed to this vellus hair instead of the terminal hair. And so patients with, you've heard the term peach fuzz, like kids with peach fuzz on their face. It's just a lot of little vellus hairs that are on their skin. And we actually have vellus hairs throughout our entire body. It's just throughout most of our skin of our body. It's just that it's very difficult to see them in most cases, but they produce thin white hairs. A little bit more about the anagen hair follicle. So you can see that the base of the anagen hair follicle goes all the way down into the subcute. So if you were to biopsy somebody's scalp, if they had normal hair growth, you would see a lot of these anagen hair follicles there. The lower segment consists of the base of that bulb of the hair follicle all the way up to what we call the bulge. The bulge is where the erector pili muscle is connecting down into the hair follicle cells, and particularly the outer root sheath here. And the bulge is actually where a lot of the hair follicle stem cells live. The region from the insertion of the erector pili muscle all the way up to the sebaceous gland insertion, that is called the isthmus. So the top from the sebaceous gland up to the opening is called the infundibulum. And the way that people used to remind or teach us how to remember the infundibulum is you can think about this is like a fun slide that you're sliding down. It's fun to slide down here. So that's the infundibulum. The opening of this hair follicle is called the ostium or the follicular ostia. And just this whole portion here that's within the intraepidermal segment is called the acrotrichium. But most of the terms are used are follicular ostia, the infundibulum, the isthmus, and then you've got your lower segment as well. So the isthmus is technically defined as from the erector pili muscle to the sebaceous duct. And that's an area where you have something called tricholimal keratinization. So tricholimal keratinization means that the keratinocytes produce the keratin and it skips over the keratohyalin granules. So what you'll end up seeing more often than not is when you have a cyst, for example, that develops from that, you'll actually not see the keratohyalin granules. And the most common cyst that fits that description would be a pilar cyst. So a pilar cyst actually has tricholimal keratinization. Now, an epidermal inclusion cyst, which usually develops much higher up where you have the normal production of the granular layer, you'll see that in the cyst where the lining has the granular layer, and then the center part has keratin that looks a lot like the basket weave stratum corneum. That's called the lamellated keratin. Whereas in a pilar cyst, you'll have more compact keratin that's more reminiscent of this trichohyalin production. The bulge, as I said, it's at the insertion of the erector pili muscle. And that's where you have the follicle stem cells. So in conditions such as licum planopilaris, which is a scarring alopecia, you have lymphocytes that attack, it basically attacks this area here, the isthmus of the hair follicle. But what happens is you actually lose your hair follicles over time. It's destroying the hair follicle stem cells, and you lose the whole hair follicle and you get this perifollicular fibrosis. And so that's how lichen planopilaris becomes a scarring alopecia. In alopecia areata, you have a lot of inflammation around the bulb of the hair follicle here, and that causes a transition from anagen up to catagen and then telogen hair follicles. And so you have this anagen to catagen shift, but you don't actually lose the bulge of the hair follicle, and it's not a scarring alopecia. So eventually the hair can recover and stay and grow back. And that's why in alopecia areata, we see growth of the hair again eventually once we calm down the inflammation that's occurring mostly at the bulb of the hair follicles. That's just an example of how if you understand normal histology of the hair, you can understand a little bit of the alopecia pathology. All right, now the lower segment consists of the stem and the bulb, as we mentioned. The bulb has the dermal papilla, which sits underneath this little U-shaped part of the matrix. The matrix cells are all throughout within here. And you can think of the matrix cells as like the basal layer of the hair. And then the matrix cells also have intertwined within it melanocytes. So this is kind of a nice little basal, it's almost like a basement membrane of the hair follicle. And that's where you get your pigment in the hair itself. So when we age, we start to lose our melanocytes and our melanocyte function. And so we actually lose our hair pigment and we go gray, as we say. So that's why as we get older, we actually get a lot more gray hair there. Just another overview of the hair growth cycle. So we have our three major hair follicle cycles. We have our anagen, our catagen, and our telogen. As I said, the anagen represents the active growth cycle. If you did a cross section of an anagen hair follicle, you'll see abundant clear cells that are making up that outer root sheath. The outer root sheath is the thicker part. You can go transition into the inner root sheath, which is known as Henle's layer, which is a thin outer part of the outer root or the inner root sheath. And then you have Huxley's layer, which is a little bit thicker part of the inner root sheath. But this is an anagen hair follicle. And it can last, 2 to 6 years, but on average 3 years per anagen hair follicle. 84% of your hairs, or essentially 8 out of every 10 hairs, are in your anagen hair cycle. When it's time for the anagen hair cycle to go to telogen, it first has to go through catagen, and that's the involution phase. So you'll start to lose that bulb in the subcutaneous. It starts to migrate up. And you'll have this fibrous stella, or this little streamer of collagen that's kind of left behind. And the base of the hair follicle starts to rise up even more. And if you were to cut a cross section, you'll see cells actively undergoing apoptosis. And that gives you this really eosinophilic flame appearance, which some textbooks actually dictate this as a telogen phase. And that's kind of a representative of a catagen that's nearing the telogen phase, especially if it's higher up here. You get this flamethrower appearance. You can also still see apoptosis here in the telogen phase. So this kind of flamethrower appearance, which I'll show you on one of the upcoming slides, can represent like a catagen telogen phase. The catagen is an involution phase that only lasts 3 weeks, and that represents only 2% of hairs. And then telogen is the resting phase. It's easy to lose the hair follicles in the telogen phase because when they go back they lose the hair follicle before they go back. They lose the hair shaft before the hair follicle goes back into the anagen phase. So this resting phase lasts about 3 months. It represents about 14-15% of the hair follicles. And here's just, if you were to take a cross section here, what you might see. It's kind of basaloid island. It almost may look like a basal cell carcinoma for those of you familiar with it. And oftentimes you can actually stain positive for BRAF4 if you were to cut through one of these. So this is kind of where it gives you a sense of that basal cell carcinomas can stain for certain proteins that mark basal cells. BRAF4, which we will mention, is a big marker of basal cells. Of course, the erector pili muscle is maintained during all these cycles. The sebaceous glands, the attachments, all retained as well. The hair shaft is mostly retained. Now, if somebody undergoes a process called telogen effluvium, what happens is you have a shift from anagen into the telogen hair follicles, where a significant amount of hairs, maybe closer to 30 or 40%, or even 50% of the hairs are in the telogen phase. And then they lose hair much more frequently. And this can happen after stressful situations to the patient, or illnesses, or even COVID-19 has been associated with telogen effluvium, that type of hair loss. It's a non-scarring hair loss because you still keep your basic bulb intact and you still keep all the material in each follicle or folliculosebaceous unit, pilosebaceous unit, to be able to recreate antigen again. But it takes time to recover from that, as we know clinically, for those of us who have treated these patients before. You often have more telogen in hair follicles and miniaturized hair follicles, even in alopecia. That's due to hormone imbalances. So in androgenic alopecia, you may have a little bit of an anagen to catagen to telogen shift, but you're going to have much more miniaturized hair follicles. You can still have plenty of hair follicles in androgenic alopecia that are in the anagen phase. And in most conditions, if it's a non-scarring alopecia, you'll see a lot of anagen hair follicles still, because again, most of your follicles are in anagen hair. So you got to look for other clues to be able to diagnose the pathology. And we'll get into alopecias much more later in the year. Catagen hair follicle, just an example, as I mentioned. You see these brightly eosinophilic areas that are undergoing apoptosis. And here's a telogen follicle. This is taken from Dr. Elson's textbook, but you can see the nice flamethrower appearance down here, which depending on the level of where this is at, it could be a representative of a catagen or a telogen, just depending on what level you're cutting into. But this typically is representing some active transition and active apoptosis that's happening among the hair follicle cells. Moving on to sebaceous glands. So sebaceous glands can open into a follicle at the infundibulum, as I mentioned, or into the epidermis directly. So in cases such as nevus sebaceous, you can have opening of these sebaceous glands directly into the epidermis without being associated with a hair follicle. You can also have specialized types of ectopic sebaceous glands that are not associated with any hair follicle. So before I mention those specialized types, I will say that the sebaceous glands are typically absent on the palms and soles. So you're not producing that oil on your palms and soles naturally. You're producing sweat material. Sebaceous glands enlarge at puberty. They can also be enlarging on patients that are growing older that have rosacea. So you could have rhinophyma with abundant sebaceous gland proliferation in the nose. You can have sebaceous hyperplasia developing on the face. This is a very common cosmetic issue in our clinics. Sebocytes are mostly white cytoplasm with this vacuolated appearance, and the rim of the sebaceous lobule is a very thin purple. When you start to get a really thick purple rim and you've got cells that are appearing more blue in terms of their cytoplasm, you can think about a sebaceous adenoma developing. These are larger. And you could also have something called a sebaceoma, in which it's a sebaceous proliferation, but you don't have as many of these well-differentiated sebocytes anymore. And we'll have specific lectures on sebaceous neoplasms. Specialized types include the meibomian glands, which are on the eyelid. You can have Montgomery tubules, which are on the areola. You can have Fordyce spots, which are on the genitals and or on the mouth, in the mouth and on the face as well. Apocrine glands are responsible for producing a special type of secretion, such as under the axilla. A lot of pheromone chemicals are produced in the axilla. This is also where the body odor comes from apocrine secretion. Apocrine secretion is present in areas of breast tissue as well, and can be even present in sebaceous or nevus sebaceous rather. Apocrine glands empty into the follicle at the infundibulum, similar to sebaceous glands. The highest concentration include the axilla, the inguinal area, as well as the perianal area. There are no myoepithelial cells around apocrine glands, as opposed to eccrine glands, where there are a lot of myoepithelial cells. And if you look at the secretion, the way that it looks when the material is coming out, you'll see these little snouting, these areas, invaginations of the cytoplasmic contents. into the lumen of the duct. So that's called a snouting or a budding pattern. Apocrine glands are often a clue as to the pathology. So if you see some apocrine glands in your digital slides or your still shot slides, that should give you a hint of the location on the body. Eccrine glands directly, they empty directly into the dermis. So they have the glandular portion that is more coiled up, and you can cut through cross sections or a little bit of a longitudinal section. You see this nice coil. Around the eccrine gland, you have these myoepithelial cells that allow for constriction and production and release of more sweat, depending on neural stimulation, et cetera, and temperature regulation. So the sweat gland produces the sweat material, and then when it's time to sweat, it'll actually produce it, and it'll go up these little ducts all the way to the outside. So the dermal duct is here, and the acrosyringium is the portion where the sweat actually exits the skin. That's the epidermal portion of the duct. There are many different neoplasms that can arise from eccrine gland cells. We don't have time to go over all of them during this lecture, but there are various entities such as poromas or nodular hydradenomas, dermal duct tumors, even hydroacanthomas simplexes that can all arise from eccrine gland cells and duct cells. So keep this in mind, that this is a very important source of neoplasms that you're going to need to know for the skin. As you would imagine, the highest concentrations are on the palms and soles. You do not have eccrine glands on the lips. You do not have eccrine glands in the nail beds, as well as the labia minora, or the gland's penis. And as I mentioned, the myoepithelial cells encircle the gland epithelium. It's important to understand the difference between artery and vein walls, and I know that you've studied this before in medical school. So the most striking difference is going to be in the elastic material that's within an arterial wall. And again, that's because it's got to deal with the pumping change and the pressure within the lumen in arteries. And so it has this elastic membrane, which can stain with a special type of stain called Bierhoff-Van Giesen. And the venous wall is much thinner. It's got more smooth muscle, a lot less elastic tissue. Both types of vessels are lined by endothelium. Now, within each layer of these normal vessels, you can have pathology develop. So you can have pathology developing mostly from the endothelium. If you've heard of angiosarcoma, you can have malignant endothelial cells, and it's a very deadly type of cancer. But an angiosarcoma is essentially a malignant vascular proliferation. You can have angioleiomyomas developing from the smooth muscle of the vessels as well. You can have venous hemangiomas that are primarily composed of venous dilations. You can have mixed arteriovenous hemangiomas, proliferation of both arterioles and venules. So just keep in mind that vessels are a big part of dermatopathology. Now, also you can have inflammation of the vessels too, and that's where your vasculitis comes in. You can have vasculopathy, where you've got occlusion of the lumen by various processes resulting in ischemia, and then skin necrosis and skin damage from that resulting coagulopathy or vasculopathy. And there's many different causes of vasculitis and vasculopathy, and that is for another lecture. But just understand normal artery and vein histology as well as cell biology, so that way you can understand the pathology. The tunica media is the middle part, which has most of the smooth muscle. The tunica intima is the inner part, which also has the internal elastic lamina. And then the tunica externa, which is on the outside of the vessel walls. Here you can see a nice Verhoff Van Giesen stain, which highlights the elastic fibers in an artery. So you see this nice black, swirly, squiggly, thick line. That's where your internal elastic lamina is, and that allows for the expansion and relaxation of the vessel during the pumping of blood. The veins have much thinner elastic tissue and have a thinner wall and are more dilated as well. They have a lower pressure circulating through. Veins can also have little valves as well. So if you see a valve in a vessel, you'll also be able to guess that it's most likely either a vein or some type of lymphatic vessel. Lymphatic vessels, they're difficult to see on normal histology. Normally they're easy to miss, but when they become ectatic, such as in a lymphedema, you'll see these really, really thin-walled vascular spaces with sparse nuclei that you would be in between either a lymphatic or a small vein. This pink material coming out is actually lymph tissue here. The stains that can help highlight lymphatic vessels are the most commonly used one is D240, or known as potoplanin. You can also have LIVE1 or LYVE1. Those are the most common markers for lymphatic. It would become important if you were trying to establish some type of lymphatic malformation or atypical lymphatic proliferation. And sometimes you can have dilated lymphatics and impaired lymphatic flow in conditions such as elephantiasis nostraverticosa. You can have angiosarcomas actually developing in chronic lymphedema after removal of breast tissue and a syndrome called Stewart-Treves. So these are just important things to know about dilated lymphatics, but it's important to understand that it's hard to see normal lymphatic vessels unless they're dilated and ectatic in pathology. But without the lymph system, the skin would be completely dysfunctional. So it's a very important way for the skin to release contents from the cells in the skin and deliver it back up to the heart. And get circulation and movement of various types of waste out of the body, but also just kind of supporting the exchange of materials from the skin to the rest of the systemic circulation. Next is a glomus body. So glomus cells are specialized types of cells that are present in areas called the Sequat-Hoyer canals, and they regulate temperature by acting as essentially a sphincter to turn off the blood flow to superficial dermal vessels. So in aspects of temperature regulation where you need to stay cool, it's going to restrict blood flow to the outer part and try to keep all that warmth inside of the body. And in cases where you need to release a lot of heat, they're gonna relax the vessel wall and allow for more blood flow to the superficial vessels to release heat through the skin. But you can actually get tumors developing from these glomus cells. And so you can have something called a glomangioma, which oftentimes even develops under the nails, the nail bed. You can have a glomus tumor, that can develop under the nail, but you can also have glomangiomas, which is kind of a combination of a hemangioma and a glomus tumor. So what happens is you have these little small glomus cells that proliferate and develop these large lumen here of vessels, and you'll have this wide, it almost looks like a hemangioma, but it has all these monotonous cells around it. And that's a glomangioma. It's just a combination of the word glomus tumor and hemangioma together. It's an important entity you'll need to be able to recognize. And we'll show you examples of that in later lectures as well. Glomus bodies are most frequent on the fingertips, the toes, the nail beds, and the face, as well as the nose. So if you think about these areas of temperature regulation where it may be a cold day outside and you want to keep your face warm, the glomus cells are going to go to work and try to constrict blood flow. And if you are getting really hot and you need to release a lot of heat, then your face is going to get really red as they relax and allow more blood flow to the superficial dermal vessels. Nerves, which can be involved with sensory and motor, but typically in the skin, you're going to find nerves that are involved in sensory. So this is a normal nerve. You can see this nice wavy pattern. It's got these cells that kind of are waving along like they're flowing in a little river, and they have this surrounding gray cytoplasm. It's important to recognize normal nerves in histology, because if you see a neural neoplasm, then you'll say, oh, this looks neural, and you'll be able to kind of lower or narrow your differential to schwannoma, or you could be looking at a neurofibroma, palisated encapsulated neuroma. So it's important to really recognize neural cells normally, but also when you're looking for perineural invasion in such tumors like squamous cell carcinoma or basal cell carcinoma, or microcystic adnexal carcinoma, these tumors actually go perineural. And it's important to be able to recognize that there are neoplastic cells that are infiltrating the normal nerves. And then you would want to measure that, because if you have a nerve that's greater than 0.1 millimeters in terms of thickness, and it's involved by a neoplasm, that becomes important for prognostic, in a prognostic sense. And a lot of the surgeons are going to want to know that as well, just to kind of understand how aggressive this tumor is. So definitely look for normal nerves and also perineural invasion. There are some specialized sensory structures in the skin. So the Meissner's corpuscle is responsible for the sensation of touch, even light touch. So if you're getting a light, massage, or someone lightly touches your skin, or a small bug is crawling on your skin, or the wind is blowing on your skin, you're going to feel that sensory, that very fine touch sensation. And the Meissner's corpuscle, which is present every fourth dermal papilla, is responsible for translating that mechanical signal down to the deeper nerves and then all the way up to your brain, so you can feel that sensation. So really, Meissner's corpuscles are kind of an under-recognized and underappreciated part of the skin, but very important. And it looks almost like these vertically oriented potatoes or something, or little cocoons sitting underneath the skin there. In dermatopathology, people often hallucinate that things look like normal day objects. So you can create your own analogy of what this looks like to you. And please let me know. I find it fun. These are heavily concentrated in the palms and soles region. So if you touch your palm and you touch your sole, you're going to feel that sensation, and that's the Meissner's corpuscles working. The Pacinian corpuscle, again, what does it look like to you in a normal object? It looks like an onion to a lot of people. So this is an onion shaped neural structure. It's a specialized sensory structure, and it is responsible more for pressure sensation, also very common in the palms and soles, but also the deep dermis and the subcutis. So you may run across this in your normal skin specimens. That's a Pacinian corpuscle. And again, if someone were to feel deep pressure sensation or vibration, you're going to feel it through the Pacinian corpuscle. In terms of site variance of skin, if you're looking anywhere beyond the trunk or proximal extremity skin, which is your normal kind of regular skin histology, if you're looking at the scalp, you're going to have different features, as well as the face, the nose, the eyelid, the ear, the axilla, the areola, acral or volar skin, and the mucosa. These are special sites of the skin. And you should be able to look for features that will help you recognize these areas of skin. You could be tested on just being able to recognize these areas of skin. So if someone gave you a digital slide and says, what part of the body is this? Or they showed you a still shot, an image of dermatopathology, and said, or dermatology, histology rather, not pathology, but just histology of the skin. They want you to know what the normal site looks like. And so there are some key features that can help give you the answer if you're asked this on an exam, but also it's just important to be able to recognize site variants of skin, because let's say in the rare case that there is a mix-up of specimens in the lab or something in error, if you're able to recognize, hey, this is not the normal histology of that site. So I think that the specimens are mixed up. You can actually catch an error and be able to correct that. And so it's very important to understand site variants of skin. And it can give you a hint to the pathology as well. So if you notice a pathology happening and you can recognize the site, then that actually increases the chance that you're going to get the question correctly or the diagnosis correct as well. So the scalp is full of hair follicles. You can see 1, 2, 3, 4, 5, 6, 7 antigen, 8 antigen hair follicles here, just even in this cross section. You can also see higher level telogen hair follicles as well. You can see erector pili muscle. And I want you to keep in mind when you're counting hair follicles, if you just see one hair follicle in a plane of section, you're going to count that as one because they're going in and out of the plane of section. So every little hair follicle you see represents one hair follicle more often than not, because the hair follicle is not going to cross back and forth into the same plane of section. It's either going to go in and out in one level, or you're not going to see it at all. So just keep that in mind. So here we've actually got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14 follicles in this one section here. This could be an excision specimen. So this is the scalp. If you see a lot of antigen hair follicles, it's a pretty thick dermis, and you have a nice subcu, you can recognize it's the scalp. The face in older people typically has a lot of solar elastosis, which is this blue degeneration of the dermis, and we can get into that in another lecture, but the solar elastosis stains very light blue on H&A. And this is a result of chronic sun damage. The face also has very thin epidermis, and it's got a lot of sebaceous glands. So you'll see, and also very thin cross-section diameters of vellus hairs. So if you think about the face, if someone was to biopsy the cheek of a chronically sun-damaged skin, this is the typical picture here. You've got thin epidermis, a lot of solar elastosis, some sebaceous glands, and some vellus hair follicles. Terminal hairs may only be seen in the beard area. So if you biopsied somebody's cheek in the beard area versus their central face cheek that doesn't have the beard, you're going to see different histology there. So keep that in mind. The nose can have a lot of sebaceous glands. So this is probably somebody that had like a rhinophyma, where they're having tons of sebaceous lobule proliferation. But the face in general has a lot of sebaceous glands. So you may see a lot of sebaceous glands, and it may not even be a pathology. It may just be the person has a very sebaceous face. So if you see a lot of sebaceous glands and a very thin overlying epidermis, you need to be thinking that you're on the face, but particularly the nose if you see this type of abundant sebaceous presence. The eyelid is, you're going to be able to recognize the eyelid. I think that's something that's very highly testable, because you're going to be able to see the apocrine glands, as I mentioned. You're going to be able to see a very thin overlying epidermis. You'll be able to see skeletal muscle even, because it's so thin. Oftentimes with biopsies, you're getting into the skeletal muscle of the eyelid. You'll see numerous hair follicles, and you'll even see some sebaceous glands too. So you can have those meibomian glands, as I mentioned. The ear also has thin epidermis. It's got a thin dermis and abundant subcu before you get into the cartilage. So this bluish porous material here, if you remember from your normal histology, is your cartilage. So if you see cartilage, you're definitely going to be thinking that you're on the ear. Now, the most biopsies we do on the ear are going to be for ruling out basal cells or squamous cell carcinoma. or actinic keratoses, but also chondrodermatitis nodularis helices is a common entity on the ear. And what happens is with chronic pressure on the ear, when patients are sleeping at night and they're sleeping on the same side, at that chronic pressure creates local ischemia. You actually get an ulcer developing with a fibrin deposition at the base of the ulcer. And sometimes you can see the cartilage actually extruding up into that ulcer, but not always, and most often you don't. So if you have a biopsy with a little ulcer, but no malignancy and some fibrinoid collection, you can think about chondrodermatitis nodularis helices. Most important thing for the axilla is that you'll notice a relatively kind of normal epidermis, maybe a little papillomatosis or acanthosis, but the most important thing is if you see apocrine glands in a histology section, you should be thinking axilla is your site. The areola is going to be recognizable by this kind of thicker papillomatous epidermis, but the smooth muscle bundles you see down here in the deeper dermis, that's going to key you in that you're dealing with an areola. So if you get a biopsy that on a test and you're not sure what they're asking you for, you've got some smooth muscle, you've got some apocrine glands, you can think about an accessory nipple as the diagnosis that they're trying to get you to recognize. Acral skin or volar skin, you have a thick hyperorthokeratosis. This would be the palms and the soles, for example. So you think about that thick skin on your palms and soles, it's got to deal with a lot of mechanical stimulation throughout life. So thick stratum corneum here. And then the stratum lucidum is kind of this artifactual layer of skin that you most often see in the acral or volar skin. It's kind of this clear spacing that separates in the histologic processing. Then you go into your stratum granulosum, which is very thick as well in the acral or volar skin, so hypergranulosis, just because of it being on that site. And then you have, it's important to remember that you've got fewer melanocytes naturally. So if you have an acral junctional proliferation or a compound acral melanocytic proliferation, or even an acral melanoma, it becomes important to recognize melanocytic proliferations within the acral skin. And we won't get into it because it's a bit of a difficult topic, but we will discuss acral melanocytic proliferations in further lectures. It's also important to know that you don't have any pilosebaceous units. So I would say that probably one of the most highest yield diagnoses to be able to understand acral skin and inflammation is going to be something like pernio or perniosis, where you have dense perivascular lymphocytes. And if you see dense perivascular lymphocytic inflammation on acral skin, you should definitely be thinking about the diagnosis of perniosis, which is a type of inflammation that you can either see in lupus or autoimmune connective tissue disease, or even in areas of cold, extreme cold, where people are getting inflammation after constriction of the vessels. And it can be seen in a variety of autoimmune diseases as well. And then there are some infectious diseases such as COVID-19, which has actually produced a pernio-like presentation, especially even in young kids. So just keep in mind that it's helpful to be able to recognize what site of skin you are on when you are looking at for dermatopathology. Mucosa is, we get a lot of mucosal biopsies in dermatology. So it doesn't have that stratum corneum. It doesn't have a granular layer. So if you don't see a stratum corneum or a granular layer, and you are convinced you're not on a normal skin site, but rather the mucosa, that's going to support your thought. So you'll have these glycogenated keratinocytes, which look more pale. Along with that lack of stratum corneum, lack of granular layer. And there's areas that look like retained nuclei, and that's a normal phenomenon in mucosa. It's not perikeratosis in the traditional sense, but it looks like perikeratosis. And you also do not have pilosebaceous units. So yes, you should not have hair or oil glands in your mucosal surface. You often do find dilated vessels and mucosal surfaces as well. So the most frequent mucosal surfaces you will see are biopsies from the lip, where you might see a transition from the outer lip to the inner mucosal surface. You may also see biopsies from the labia and or close to the vagina that's actually transitioning to mucosal surface. And the penis as well is considered a mucosal surface site as well. So you do have to understand normal mucosa histology to be able to interpret the abnormal. So what can develop in the mucosa? You can have squamous cell carcinomas, you can have basal cell carcinomas, you can have inflammatory processes such as lichen sclerosis or lichen planus. You can have Zuhn's balanitis, where you've got a lot of plasma cells intercalating up into the dermis at the dermal epidermal junction. You can have infectious disease happening in the mucosa, herpes, for example. And again, we will go over all of this at some point in the year. You can also have contact dermatitis happening in the mucosa, irritant or allergic contact dermatitis. You can have infectious diseases like syphilis with abundant plasma cells. You can have adnexal tumors. You can even have metastatic disease going to mucosal surfaces. So just be familiar with mucosal surfaces as a site. We are entering into introductory material and special stains in immunohistochemistry, and this is just an introductory lecture. So special stains, what they mean is they are not antibody mediated. So these are not immunohistochemistry stains, these are special stains. So they're chemically based stains that allow for you to highlight certain types of materials, which can be helpful in working up different diagnoses. So periodic acid shift or PAS stain will test for the presence of basement membrane as well as glycogen, as well as fungus. And so if you use a PAS stain and you do diastase, it should dissolve glycogen, but it shouldn't dissolve the fungal wall or the basement membrane. So if you have a PAS positive diastase treated signal is still there, then it's going to be a fungal or basement membrane material. But if you do PAS and diastase treatment and you lose that material, that's going to be your glycogen that was lost. A gomorrhomethamine silver or GMS stain is a silver-based stain that can actually highlight fungal elements, which I like to use mostly in my practice to look for onychomycosis or tinea, whether it be a dermatophyte infection in the skin or candida, or even an angioinvasive disease, we can highlight fungal elements. Congo red will highlight amyloid deposition. Prussian blue will highlight iron. And von Casa will highlight calcium. There's also another stain called alizarin red, which will highlight calcium. And Fontana-Masson will highlight melanin black. So we'll go over examples of these now. Here's your example of the PAS. You can see when it's positive, it's a magenta color. So it highlights the basement membrane. As I said, positive PAS with diastase treatment means that the diastase did not dissolve the PAS signal. That's present in neutral mucopolysaccharides in basement membrane as well as fungi. But if you were to do a PAS and you treat it also with diastase and it was negative, then that represents glycogen deposition. Here is a nice image of a positive GMS stain for fungus. So the silver results in black highlighting of hyphal structures and spores. Congo red highlights amyloid. And so on your normal stain, you'll see a brick red color on non-polarized light, whereas if you put it under polarized light, you'll see this apple green birefringence with polarized light. So I think in medical school, we all had to learn about that. And it becomes important in entities such as cutaneous amyloidosis, which you can often see in hematopoietic disorders where you've got antibody light chains depositing in the skin. Prussian blue can help separate if you think something is melanin or hemosiderin or iron, you're not sure. Prussian blue will actually highlight the brown pigment blue, but it will leave alone the brown melanin pigment. And so if you were to do a Prussian blue stain, you'll highlight the blue hemosiderin and the brown, melanin will stay brown. It's a very pretty stain. And it's, I don't use it a lot, but if I really want to establish hemosiderin versus melanin, I'll use the Prussian blue stain. Again, hemosiderin develops usually from erythrocytes that are extravasated, but also it can be after a biopsy was done and there was a certain type of anticoagulation solution put into the biopsy wound. That's called Moncel solution. So the Moncels will actually leave iron deposit within the skin. And then if you're concerned in a section, you're not sure if that's Moncels or if there's some type of pigment, neoplasm or something, you can do an iron stain or Prussian blue stain. It'll highlight that Moncel solution blue. Here's another example of just hemosiderin or iron within the liver. Von Casa is often used for calcium stains. If you have a biopsy to rule out calciphylaxis or calcinosis cutis or pseudoxanthoma elasticum, which are entities we will go into in different lectures, but they involve calcium dysfunction and deposition in vessels or in the skin or around elastic fibers, then you can see that the calcium actually highlights black. On H&E, calcium is usually a deep purple, so you can usually recognize it even without doing the Von Casa, but sometimes in calciphylaxis, it's helpful to use this Von Casa as supporting evidence to find these small vessels that are occluded with calcium deposits in calciphylaxis. Fontana-Masson highlights melanin pigment granules black. So here's an example of a vitiligo patient where you have the normal non-depigmented skin or just the normal adjacent skin with a nice Fontana-Masson positive melanin granules. And then when you get into the depigmented skin where there's no longer any melanocytes producing melanin, you have no black signal here. So this is a nice borderline representation of vitiligo. Now, just a brief introduction in immunohistochemical stains. And before we get into it, I just want to say that, you're never going to remember the immunohistochemical stains from the first time you hear them, but you will eventually become comfortable with them. They will become more second nature to you as you think about them, but you do have to spend some time doing practice questions and seeing cases and thinking about the immunohistochemical workup. And that's really going to help solidify the practical utility of these immunohistochemical stains. Now, again, I am a cell biologist, so I find it fascinating that we've acquired so much knowledge about cell-specific markers and markers that can help with, establishing malignancy and proliferation of cells, et cetera. So I love immunohistochemistry. I find it so fascinating. And there's always a lot of potential for research projects and different studies that can happen based on looking at how certain proteins are expressed in various types of entities, whether it be neoplastic or inflammatory. The possibilities for research is really endless. And this, when you learn more about immunohistochemistry, you also can correlate that with molecular technology as well. So you can learn a lot about human physiology, histology, and dermatopathology through immunohistochemical stains. We will go over epithelial markers and melanocytic markers and just like fibroblastic or mesenchymal markers, and then we'll be done with this lecture. So epithelial markers typically include a mix of keratins as well as other proteins that are related to expression of in keratinocytes. So we'll just kind of go through this row by row. CKA1/3 is it's actually a mix of antibodies that can target both high and molecular weight cytokeratins. And what this does is it stains epithelial cells of all different kinds, whether it be the epidermis, the hair follicles, the sweat glands. It really paints the whole section brown where you have anything related to epithelial cells. So it marks the epidermis, it marks adnexal epithelium, including follicles and glands. And this is helpful if you're just trying to screen for some type of squamous cell carcinoma in the dermis, and you want to make sure that there are no spindle cells that are making keratins and things like that. So A1/3 is a very good broad screen. CK5/6 is also a cytoplasmic marker, which marks low and intermediate molecular weight cytokeratins. It's important to do CK5-6 and if you're suspecting some type of squamous cell carcinoma or even a sarcomatoid squamous cell carcinoma, spindle cell squame that may be producing keratins, CK5-6 is also a good screen to do. But unfortunately, some squamous cells are poorly differentiated and they actually do not make keratin normally. And that's where the P63 comes in. And I don't have P40 listed here, but both P63 and P40 are very useful for this. They're a nuclear stain, so they actually highlight the nuclei of squamous derived primary epithelial cells. And they mark basal and spinous cells, they mark sebaceous glands, and they mark myoepithelial cells of sweat glands. So P63 is helpful if you're trying to establish some type of primary epithelial origin of a tumor. P63 can be very helpful. And I often do it when I'm looking at tumors on the scalp that look like they're spindle cell, epithelioid cell, and we're trying to make sure it's a atypical fibroxanthoma or a pleomorphic dermal sarcoma versus a spindle cell or sarcomatoid squamous cell carcinoma. So we'll do P63. CK7 is very high yield if you're worried about Paget's disease. So CK7 is the key stain you want to do if you're worried about Paget's disease, but it's a cytoplasmic stain and it oftentimes is associated with metastasis, but usually it's just broadly speaking, it's expressed in tumors that arise above the diaphragm. Okay, so breast cancer, for example, lung cancer, these will be CK7 positive usually. And if you have a CK7 positive process and it's CK20 positive, which we'll get into next with CK20, you can think about bladder cancer or pancreatic metastasis. CK20, though, is what you usually think about as representing below the diaphragm tumors. So oftentimes they're present in GI malignancy metastases. Usually the GI malignancy metastases are negative for CK7. CK20 is a cytoplasmic stain, but it can also show up as a perinuclear dot stain in Merkel cell carcinoma. Merkel cell is a specialized type of cell, mechanosensory cell, and it's actually expressed highly in Merkel cells. CK20 is expressed highly in Merkel cells. So the broad stain that you're going to want to use to rule out Merkel cells is going to be CK20. CDX2 is a great marker for metastasis of tumors with an intestinal type differentiation. So the vast majority of cases of GI malignancies with GI metastasis will express nuclear CDX2. TTF1 is a nuclear protein stain that often is derived from lung or thyroid metastases. EMA is a cytoplasmic marker that's normally seen in sebaceous glands as well as sweat glands. CEA is a cytoplasmic marker normally seen in sweat glands. And BREP4, which I use this probably more frequently than any other immunostain, just to confirm, especially on cases of the face where you might have a borderline mixed bulbous Bowen's or squamous cell in situ versus a basal. You really feel like it's a basal, but you want to prove it just because this is on the face. You want to make sure you're not missing a basal cell. You want to confirm it. Do a BREP4 stain. It's a membranous stain that will highlight basal cells and leave squamous cells negative. So positive in basal cell, negative in squamous cell. It's very useful when you're wanting to confirm a basal cell carcinoma, or if you get negative, it pushes you towards the squamous cell carcinoma. These are a list of melanocytic markers. So I'll start at the bottom and actually say I prefer SOX10 to mark my melanocytes because it's nuclear. It's a very clean stain. It highlights the nuclei of the melanocytes and allows you to kind of not overestimate contiguous growth if you're looking at a melanoma. And so it'll help separate out melanocytic hyperplasia versus true melanoma in situ. It also shows you very clean pagetoid upward migration, which again, some of these terms you may not know well if you're a beginner, but please remember that SOX10 is a very useful stain for melanocytic markers, but also keep in mind that it can mark desmoplastic melanoma very well. That's a special type of spindle cell melanoma that spreads into the dermis. Desmoplastic melanomas are a subtype of melanoma that unfortunately is often negative for melan, which is another common cytoplasmic marker of melanocytes. So SOX10 is a really good screen to make sure you're not missing a desmoplastic melanoma. It is also positive in other neural neoplasms. So SOX10 marks neural cells as well. So schwannoma or neurofibroma will be diffusely positive for SOX10. Going back up to the top, S100 is a nuclear cytoplasmic stain that marks melanocytes, but it also marks Langerhans cells and dermal dendritic cells, as well as sweat glands, nerves, Schwann cells, and myoepithelial cells. That is S100. HMB45 will mark cytoplasmic of pre-melanosomes, so it's a good marker of junctional melanocytes, but if cells are expressing, if melanocytes deep into the nevus are expressing HMB45, that suggests more of a malignant behavior more often than not. So blue nevus cells are the exception to that. HMB45 will normally mark blue nevus cells at the superficial and the deeper melanocytes, but normal nevus cells lose HMB45 when you go down into the dermis. So there's what we call loss of expression with descent into the dermis. So HMB45 should be highly expressed in the junctional melanocytes and then decrease expression with descent down into the nevus. The exception to that are blue nevus cells. We just mentioned melan, which is also known as MART1. This is often used in even Mohs surgery as they're looking for margin analysis. They'll use melan. I believe that it's a good marker, but it can overestimate visually how many melanocytes are there because it highlights dendritic processes as well. And so you'll see this really broad, dense melan staining across melanocytes in a situation of melanocytic hyperplasia, which may not be melanoma. It looks bad. And so just I would recommend coupling melan with SOX10 at least to get a better picture of what's going on. MITF is a nuclear marker of melanocytes, and it can be positive in obviously melanoma, but it can be positive in other entities such as cellular neurothekioma. Cellular neurothekiomas, the differentiation is a little bit unclear, but it looks like it could be a melanocytic proliferation, but it stains negative for all other melanocyte markers, such as these other ones listed, but sometimes MITF can be positive. It also, cellular neurothekioma stain positive for a marker called CD63 or NKI-C3. We will get into these markers in other lectures. And finally, for mesenchymal markers, let me go back and just say here for melanocytic markers, there is a new marker called PRAME, which highlights malignant melanocytes much more often with a high sensitivity and specificity compared to benign melanocytes. So coupling staining lesions that you're worried about melanoma, you'll definitely want to do the melanocyte markers just to get an architectural picture of what's going on. But when it comes down to diagnosis of melanoma versus benign melanocytic proliferation, you're going to look at architecture, and you're also going to think about either malignant marker stains like PRAME. You're going to look at Ki67, which is a proliferation marker. And you'll look at other things like molecular tests, such as fluorescence and C2 hybridization for chromosome gain or loss. You may want to sequence the melanoma and look at next generation sequencing to look for specific mutations that are associated with melanoma, et cetera. So just keep in mind that melanocytic markers in general are just to mark melanocytes, but it doesn't tell you much about the actual malignant status of it. You have to use more information. So that's just a point I wanted to make. And we'll get into this in our melanoma lecture. And finally, mesenchymal markers. So desmin is a stain that marks nuclear and cytoplasmic, and it can be seen in skeletal and smooth muscle, including vascular smooth muscle. This will be important if you're worried about something like a leiomyoma or leiomyosarcoma. If you want to prove smooth muscle differentiation, desmin's a good screen. Sometimes it's negative and you'll want to do other smooth muscle marker differentiations such as myogenin or MyoD to look for rhabdomyosarcomas and things like of that nature. SMA is probably the most common stain for looking at mesenchymal or muscular derivation. It can stain membranous and cytoplasmically and stain smooth muscle, including vasculature. There is an entity called atypical fibroxanthoma, which is usually negative for every stain, and that's how it's diagnosed. But keep in mind that there's a good percentage of atypical fibroxanthomas that stain for SMA. So that's not the perfect stain. I would say desmin's probably a more high yield stain to do when you're trying to rule out smooth muscle differentiation. CD34 is a membranous stain, and it's positive in a whole host of things, actually. So it can be positive in vascular endothelial cells. So if you just stain a normal skin with CD34, you'll see the vessels highlighting. There is an entity called dermatofibrosarcoma protuberans, which is a dermal-based neoplasm composed of story-formed spindle cells. And that CD34 is very positive in DFSPs, but negative in a benign variant of fibrohistiocytic process called dermatofibroma. So CD34 is probably the most high yield stain to do if you're trying to exclude DFSP versus DF. And we'll get into all these specifics in different lectures too. It can stain trichoepithelioma stroma, but usually the BCC stroma is negative. I don't use this a lot, but this is something that is out there. Spindle cell lipomas can be positive for CD34, sclerotic fibromas, and solitary fibrous tumors as well. But there is a stain called STAT6, which is even more high yield for solitary fibrous tumors. CD31 is another common stain that can mark vascular endothelium. Not listed here, but I will mention it, is an ERG stain spelled ERG, which also marks vascular endothelium. Factor 13A is used in conjunction with CD34 just to make sure that you're not dealing with, or to solidify you're dealing with a dermatofibroma. And so it'll be diffusely positive in most dermatofibromas, but negative in DFSP. And D240 or potoplanin, as I mentioned, potoplanin is the name of the protein and D240 is the name of the antibody that targets potoplanin. It's a membranous stain and it highlights lymphatic endothelium. So that is just a little bit of an introduction into normal histology and normal immunohistochemistry. If you felt like some of that was a lot of information or you didn't understand a lot of that, don't worry, you're going to hear it over and over again in various contexts and it'll start to make sense for you. So again, just congratulations on listening to this entire lecture. And if you have questions for me, please do not hesitate to reach out.